All right, so we're going to have both Dr. Vogel and Dr. Lieu sit up here and field any questions that you may have. And if nobody has any questions, then I might pose some myself. Go ahead. Oh, hold on. There's a mic coming. Oh, well, never mind. Go ahead.
Hi, Dr. Lee. So you started to discuss how going earlier and earlier, either in treatment or in disease course, has been pretty revolutionary when you use immunotherapies. So is that as far as we're going? One, can we go earlier? Two, considering Lynch syndrome patients have a very clear genetic predisposition, can we go into the interventional space? And can you lean on the sort of the side effects?
Yeah, thanks for those questions. Interestingly, you're very, very right. As we go earlier and earlier in stages, it does seem like immunotherapy works better than, so interestingly with targeted therapy, when we give targeted therapy, that seems to work better in stage 4 than it does in stage 1, 2, and 3. With immunotherapy, the reverse actually is true. And the reason why people are thinking that is because as a tumor gets bigger and grows and spreads, it actually develops some immunoresistance, even further immunoresistance. So it's kind of, it seems like the smaller a tumor is and earlier in its development, it seems to be much more susceptible to these types of therapies. So then it begs the question, can these therapies be preventative? There are two main issues with immunotherapy. Number one, whenever you're activating the immune system, you have the ability to create a whole host of problems that you don't want, right? And the entire field of rheumatology is based off of an overactive immune system. So what can you get? You can get arthritis. You can get a pneumonitis where your lungs become inflamed. You can get a colitis where your belly becomes inflamed. And it's not because you're dealing with an infection. It's because the body's immune system is essentially attacking itself. That's the fear when it comes to things like prevention. The other thing is that these drugs are exorbitantly expensive, right? And there's, so you kind of worry about in the preventative space, what's the most effective therapy, something that's cheap and non-toxic, and then this kind of has two problems, right, in that way. But having said that, we are looking for more and more excuses to give this in earlier lines, but the data quite hasn't caught up to our enthusiasm in regards to being able to do these therapies in earlier lines of treatment.
To the prevention question is part of Dr. Lynch's presentation about leveraging our own host immune system. So not so much a pharmacologic agent, but boosting our own immune response. And that's really the work that's being done for this really innovative and I think game-changing vaccine. And so that could be something that's, as we've all learned, something that can be distributed in a public health kind of approach. And so far in early studies is showing that it's safe, it's tolerable. And so now the studies that we're part of that are led by Dr. Lynch's colleagues are to look at actually if it works. If we give these people a series of a vaccine and compare it to folks who get a placebo in 2 years, do they have fewer polyps? Do they have fewer cancers? Our targets for prevention, not so much, early stage cancers where the patient already has a cancer.
Can I do a follow-up with you, Dr. Patel? You did a great talk on the polyp distinction. Do you think there's a way to identify the specific polyps that may lend a patient to be more relevant for an immunotherapy with new high contrast, all that kind of technology advancements?
That's a great question. So to repeat the question, sort of when we do colonoscopy, is there a way to just see which polyps, might be more amenable to certain types of interventions, or see which ones are more immunogenic versus not? Is that a good summary of your question? With the colonoscopy technology, probably not, but with the tissue that we acquire, I think there's more and more work being done to do various kind of tissue-based kind of assessments to see whether polyp tissue is different than the surrounding tissue. The different kind of advanced stages of polyps have different kind of profiles than earlier stage polyps. And what we observe is that, even when you take biopsies from patients with Lynch syndrome that have normal colon tissue, not polyps, there's sort of mismatch repair deficiency that's observed just in normal appearing tissue. And so these are some of the really early changes that Dr. Lynch referred to that happen very early on in Lynch that could be a target for this type of vaccine.
Hi, I have a question. What's the percentage of microsatellite instability high colorectal cancers in Lynch? That's the first part. And then are there any, do any of the Lynch gene mutations have are any of those less sensitive to immunotherapy? If you know.
So, yeah, thank you for those questions. So, it's interesting when you look at microsatellite instability, it actually decreases as you go from stage. And, one of these things about these hypermutated tumors is that they have sometimes a hard time metastasizing because they can't, they're just almost too deranged, right? So they have a tendency, and John can tell you this, they grow locally and kind of become very inflamed, even just in the colon. But so when you look at like stage 1, 2, and 3, it kind of goes from 10 to 15% down to 5 to 10%. And then when you get to the metastatic setting, it's only 4% of our patient population. And I wanted to show you that pie graph because, again, starting to chip away at colorectal cancer 2 to 3%, at a time. But the 4% that are MSI high, we do offer immunotherapy, but you're starting to kind of chip away finally at that block for colorectal cancer. John had a great slide on the different mutations and some of the outcomes depending on the mutations that exist that lead to Lynch syndrome. But there isn't really a correlation there between the specific gene mutation and the effectiveness of immunotherapy, and most likely because once you're hypermutated, and again, the presumption is that it's going to work. But there are some other genes that might play a role in the effectiveness of immunotherapy that we're looking into, but these are beyond the kind of traditional mismatch repair. Yeah.
I was just going to add, we think probably about 10% of colon cancers that happen in the setting of someone who has a Lynch syndrome diagnosis don't have this microsatellite instability. Those are probably random colon cancers that maybe aren't driven by that same Lynch syndrome process. So most, 90%, if not more, of Lynch syndrome individuals will have mismatch repair instability.
We have somebody come up.
I'm curious, with all the research that's ongoing and the different studies, are there sufficient subjects, participants? This seems like a ripe, grounds for recruiting people to participate. If in fact there is a need for that.
Maureen, thank you. Your check is in the mail. Absolutely. I mean, this is why we do what we do to forward the care for our patients. And there are a lot of ongoing research studies. Hopefully, many of you have stopped by and met with Liz and Sammy and Sandra, who were able to tell you about some of our Lynch syndrome specific studies. But it's a collaborative effort, right? Because here we are, several hundred of us passionate and interested about this. But it requires all of us to reach out into our own communities, get our families engaged, get our, connections and, social media engaged, and partnership with lots of other centers to truly get enough patients to answer these questions. So for instance, the vaccine trial is the first trial to look at whether it actually works. It's 14 centers across the United States to get enough patients to really answer this question. So there's a lot of enthusiasm to participate, but it still requires commitment from our patient communities, which we know is donated time. Everyone's here on a Saturday, and Wes was telling me earlier about how busy his job is, and I know that this is really a generosity that our patients provide to participate in clinical trials. And I'd love to hear, Chris, your input as well, because I know you engage in research a lot in the oncology space.
Yeah, Dr. Vogel and I were able to show you that incredible data was dostarlimab and the 14 people who had 100% complete clinical response rate. GlaxoSmithKline is the maker of dostarlimab and has a trial now exactly in that space, but it's an international one encompassing essentially 300 different sites. And so it's hard. It's hard to capture a small, part of the population and then have those patients be enrolled in the clinical trials or interested in clinical trials. And again, just to echo Dr. Patel's point, this is the group that really can make a humongous difference. You guys are raising awareness. You're passionate about this. You're here on a Saturday. And this is what we need really to move the field forward. And it's what makes it so difficult, but also at this point with a symposium like this, very feasible.
Do we have time?
Yeah.
So I have a question. And I was diagnosed with colon cancer 10 years ago. And at the time I was offered a trial for statin use to prevent recurrence. But then by the time I was eligible to sign up for it, there was inadequate enrollment and we were no longer offering it. Do you know if statin use, like where a statin is used as prevention? Do you know what? I didn't really follow what ended up happening with that study because I didn't enroll.
So thank you for that question. It brings up 2 points, right? One about statins, which I'll answer, but then 2, the difficulty sometimes of prevention trials. And this is where, again, preaching to the choir, we just need more participation, right? And these studies are done in a setting where there's very, very, I think, low risk for harm. And we can answer some really, really critical questions. I know Dr. Wood would agree with this statement, who's sitting in the back. Statins are really interesting. They're thought to be somewhat anti-inflammatory. And so there's been a lot of interest in regards to statins and prevention for cancer. A lot of the data, at least in the GI space, has been more with liver cancer than necessarily colorectal cancer. I think, the answer is there's no clear answer. And so therefore, right now, we don't offer statins for primary cancer prevention or even secondary cancer prevention. But the simple fact is that we would need a really well-done trial to answer that question. But there is a lot of interest because there seem to be those properties that would impact not only colorectal cancer, but other cancers as well.
I actually have a question for Dr. Vogel. You mentioned something about some people choosing to do prophylactic surgery, and I was wondering how often you actually have that kind of uptake and whether or not this particular population would benefit from considering that.
Well, it's not a common situation. It's unusual, and it just takes, the right scenario. This patient that I was talking about is somebody who had a lot of anxiety about doing colonoscopies. It was very difficult technically to do a complete colonoscopy. I learned during her operation that she had a very elongated and twisted colon. And so, it's always just risk versus benefits. And, for certain individuals, and I think some of it is based on their age, their genotype, how difficult surveillance is, their compliance with surveillance. But for some people, it makes sense, but not for all. And so we just, it's one of those situations where we just work very closely with the patient to find out what they want to do. In this particular case, the patient was very keen on doing it to avoid having the bowel prep and colonoscopies. So that's it.
As the doc who does colonoscopies, I will say that I sent Dr. Vogel that patient because, again, as we talked about this morning, what are we trying to achieve when we do colonoscopy? If it's not going to be a complete procedure, a procedure where we actually find polyps and take them out, we're not really achieving our objective. Or if the patient's not coming but every 3 or 5 years because they dread the process. And so I think in that scenario, we can either continue the dogma of throwing the guidelines at them, and saying, come every 1 to 2 years, come every 1 to 2 years, or we can think a little bit outside the box. And it is admittedly outside the box to do prophylactic colectomy for those who don't have cancer, but one that with kind of multidisciplinary collaboration for certain scenarios, as Dr. Vogel said, might be the best solution for a specific patient if we're not actually achieving what we want to with colonoscopy.
Swati, can I ask you, is there any role now for non-invasive testing or screening for colorectal polyps or cancer and Lynch syndrome?
That is a really, really great question. I want to hear Dr. Lynch's input as well. There's a lot of interest in this. So what Dr. Vogel's referring to is we know that, as Dr. Lynch also mentioned, that colonoscopy is not necessarily perfect. And so looking at other biomarkers, stool-based markers, blood-based markers, there's ongoing clinical trials looking at this as adjuncts to kind of, in addition to colonoscopy, see if these things can pick up additional cancers. They haven't quite made it to prime time yet, but what I will say is just because of circumstances and lack of kind of colonoscopy capacity during the COVID pandemic, the group in the UK through the National Health Services actually implemented a stool-based program for Lynch syndrome patients because they couldn't get them in for colonoscopy. They gave everyone FIT tests, fecal immunochemical tests. And if they had a certain amount of blood in their stool, microscopic, those patients were ushered urgently to colonoscopy. And so it wasn't sort of replacing colonoscopy in any way, but it was a tool to help provide risk stratification to really call out the patients that need it right now. And so there's now multiple studies that are looking at some of these types of adjuncts. But Pat, what's your perspective on the role of non-invasive surveillance?
Well, I think it lends itself ideally to the design of a trial. And I think we've talked a little bit about this. You know, many of us feel that we're doing too many colonoscopies too often with too little yield in terms of completely preventing colon cancer. So I think a trial, for example, randomizing people to, you know, a baseline and then a longer interval with non-invasive testing in between versus a shorter interval, and then just do a non-inferiority thing and just see, you know, are the people that are having some other form of non-invasive screening, you know, exact type tests or something like that in between. And if it's positive, well, then we go ahead and do it at 1 year, even though we weren't planning to for 3 or so. I think lends itself ideally to a trial. Now, at one point, not that long ago, people would have said, oh, that's unethical because we know that it just stands to reason doing it every year makes sense and is going to work better than 3. But the data from Europe turn all that upside down and really call into question, you know, the efficacy of it. And so I think we're back to kind of a point of equipoise in terms of the benefit of frequent surveillance. So I think that the ground should be wide open for a trial, which would be very easy to design around that. Having said that, yeah. So, but I do have one question, and my apologies because I'm rather deaf and may have missed a question that kind of already asked what I was going to ask, and you may have already kind of answered it. But you showed some data on these patients with rectal cancer that had complete response to immune checkpoint inhibitors, and I didn't catch all the details of those, but I'm guessing that many of those were patients that had potentially resectable disease, you know, following chemoradiation and so forth. But because of concerns about maybe they're going to wind up with a colostomy or maybe they're going to have problems with the XRT effect, the thought was, well, let's go ahead and try a checkpoint inhibitor, and it worked great. So these were people where there was some reservation possibly about doing an operation. And as you guys both know, there are many situations where we've kind of taken a chance on a very promising chemotherapy in a group of patients that we kind of really weren't that excited about operating on. And then ultimately we wind up calling that definitive treatment. So my question is mission creep. So let's say we have somebody that's got low stage right colon cancer, chip shot surgically, okay, right hemicolectomy extended or not, I don't care, but you know, chip shot surgery, maybe they've got a lymph node or two, maybe not, but it's going to be an early stage standard case for surgery. But gosh, this pembrolizumab and related agents work so well. Patient's not real keen to have surgery, or maybe has got some comorbidities that give you second thoughts. I'm going to guess we're kind of maybe already doing that occasionally on an opportunistic basis, but you know, is there enthusiasm on your collective parts about that, or is that a third rail we shouldn't be talking about yet, or what?
I think we should be talking about it. You know, there's no real very low risk surgeries. As a patient once told me, the only low risk surgery is a surgery that's not being done on them. It's coming. I have to think it has to be coming. You know, why wouldn't you treat a colon cancer that's MSI high or has mismatch repair deficit with pembrolizumab? It makes sense. And so I do see it coming. And, you know, with rectal cancer in that trial, the aim was not to do non-operative management. The aim was to treat them and then restage and then use chemoradiotherapy and then see if there was complete response and then maybe do non-operative management. But the immunotherapy was so effective, they never even got to the radiation. So it makes perfect sense that a sigmoid colon cancer in the future that's MSI high is going to be treated with pembrolizumab or a similar drug because it just makes sense. And so then it'll have to be like a lot of things to think about with it, but it's got to be coming, right, Chris?
Yeah, I completely agree with Dr. Vogel's comments. It is, I mean, those trials are being designed and one is currently open and enrolling. I think it's a little bit of a trade-off between obviously a highly effective agent, but then the surveillance, right? And I did put up that slide in terms of what our patients go through when they do non-operative management. It can be sometimes intense. And so if you are having to get a colonoscopy every 3 to 6 months, I mean, that's a big ask, right? Those things, they come pretty quickly. So somebody may just throw up their hands and say, I just think I'm just going to get the surgery, right? And some people will be like, well, if I can avoid a surgery, then I would be willing to get that type of, pretty intense surveillance. And that's where, what used to be maybe a 5-minute discussion now is going to turn a lot longer, but it should because there are options and that's fantastic, but they really need to be discussed in the context of, well, what are our patients' goals? And then how can we best meet them with the available options?
Well, and a kind of a related question, and one of my concerns in like developing a trial of, looking at different intervals of colonoscopy, and I wonder if one of the things is, might we ultimately get more cavalier about our surveillance if we say, well, okay, even if you develop a colon cancer, we've got this great rescue therapy and you're going to do fine even if you have, I worry that we're going to get cavalier about that because we've got such great agents. Even if we don't want you to develop cancer, we're going to do the best we can. But even if you do, don't worry about it. We've got something great.
I think it's such a great point. And I think I think John and I are both worried that we're already being a bit cavalier, we're really pushing the envelope with non-operative management, immunotherapy before surgery, maybe omitting surgery. And this is a pretty Wild West type feeling. We're trying to make decisions based off of just 14 patients. That gives us some pause. And so we really want to do things the right way to make sure that we're not making conclusions too soon, right? And so, just bear with us as we kind of sort through this, but we're going to obviously do this all together.
I think we have to,
I was just going to say it's exciting, but I agree measured, but it's really nice to finally start to see a lot of different options, not just on the treatment side, but also on the prevention side. Colonoscopy is not the only game in town for reducing cancer risk in Lynch syndrome anymore. And we're going to see a lot more data on those things. And that's as a colonoscopist speaking.
All right. I think we had time for one more question, but if you don't want to ask it anymore, then we can wrap up. So let's thank our panelists